Thank you to the organizers. Unfortunately, I couldn't come personally. So I'll be talking about CRT ECG pre and post CRT ECG. And these days, when we say CRT, like Shanmuga was saying, there are 5 ways in which we can do CRT. One is space the his bundle. Two is space the left bundle branch area. It's always left bundle plus the adjoining septum. Three is of course the conventional. So these two are together called the conduction system pacing. Three, of course, the conventional biventricular pacing, it pace right and left ventricle. And then we can combine any of them. We could combine the his bundle pacing with the posterolateral vein pacing, or we could combine the left bundle pacing with the posterolateral vein pacing. This is called his bundle optimized CRT or hot CRT, and this is called left bundle optimized CRT or LOT CRT. And all of them will have different ECG morphologies. What is important is to look at the ECG before the CRT to decide which type of pacing modality to give. For example, if a patient has a narrow QRS and heart failure, biventricular pacing can often worsen the outcomes. So it is better that that patient goes in for his bundle pacing if possible, or if not possible, left bundle pacing. And then there are the LBBB, the RBBB, and the interventricular conduction defect. And even then, Shanmuga also alluded to this briefly, it is important to recognize which patients have a pure conduction system disease, meaning a pure left bundle branch block. Let us call it typical LBBB, where a pure conduction system pacing might do. And the other extreme, patients with pure myocardial disease, where posterolateral vein pacing or biventricular pacing is likely to be required. And some patients will have a combination of both, conduction system and myocardial disease. It is very difficult to differentiate these two, pure myocardial or myocardial plus conduction system disease, but it's not very difficult to differentiate pure conduction system disease from additional myocardial disease based on the ECG. And a lot of this can be done based on the ECG. That is why it's important to look at the ECG. So now, here's this patient with severe LV dysfunction who already has a dual chamber ICD, has a narrow QRS, a long PR interval, has recurrent ventricular tachycardia shocks, failed ablation, don't want to do one more ablation. So the best option, and the QRS is narrow, the best option to be taken in this case was his bundle pacing, replicating his narrow QRS. Now you can see a pacing spike before the QRS, but the paced QRS is identical to the native QRS. And with this, beta blockers and amiodarone were added, which took care of the ventricular tachycardia. So that's the importance of looking at the ECG before the CRT to decide which type of pacing to give. And this patient had an extensive septal scar, as you can see. So left bundle pacing, like you just listened, is unlikely to work in these cases. Now, even before that, even before all this conduction system pacing came in, we had to understand that there is no one definition of left bundle branch block. If we compare the definition of the ESC, the AHA, the Strauss criteria, or the definition used in MADIT CRT, they've all used different definitions for left bundle branch block. And there is very little correlation between these definitions. In fact, somebody did a study and found that only in 16% of patients do all these definitions correlate. Ideally, left bundle branch block should be defined like this, by intracardiac left bundle recordings. But unfortunately, and for practical purposes, this is not how the definition of LBBB as we know came about. It came from extrapolation from animal studies. So we still don't have one definition of LBBB. Now, this is what I would think as a typical LBBB or a pure conduction system disease. There should be no QAs in lateral leads. And by lateral leads, I don't mean AVL. Shamroth has clearly told that if you have a Q in AVL, that is not against left bundle branch block, and I can attest to that. But we must have a clear notch, the classical M pattern that we used to in any lead out of one AVL V5 Now, this is my working definition. There are many definitions out there. And I feel that when you have more than 2 notches in any lead, it is unlikely to be just 1 point of conduction delay in the left bundle. And if the notch is very early, that is not a left bundle branch block, because the early conduction is by the right bundle. That should be normal. It should not have a notch. If the notch is very late, it is again unlikely to be LBBB. A late notch is when the left bundle is already working. The blocked or the delayed left bundle is working. And the QRS duration is debated whether it should be a large heart or a small heart in women and men. So some examples. So this is what we classically think of as LBBB, an M-shaped pattern. Here you are seeing it in 4 leads, 1 AVL, V5 and V6. But I'd say in one of them it's fine. The QRS starts off abruptly, there is no slurring and there is only one notch. And all the criteria will say that this is left bundle branch block. Whereas if you look at this, the initial part of the QRS is slurred. And then there is a notch in the last part of the QRS. Now you may be surprised to find that the ESC and the MADIT criteria will call this LBBB, but I think this is probably better called as IVCB of left bundle branch block morphology, and a conduction system pacing or left bundle pacing is unlikely to rectify this. And this again has a Q wave in lead 1 if you look at it very clearly, and there is a notch which is happening very early in AVL, the initial part of the QRS. This is unlikely to be pure conduction system disease. This is what would be called LBBB by the Strauss and MADIT criteria, but not by the ESC and the AHA criteria. And this, I'm not sure what to call it. All the criteria would call this LBBB, but I'm not sure if it's really LBBB because you really don't have a notch here. It's only a slurring here. So I'm not sure what to call this. Now, the controversy, and this of note would be typical left bundle branch block, because a Q in AVL is not against a left bundle branch block, whereas a Q in 1 V5, V6 is against. Now, the debate on the definition will continue, but it's important to have clarity in our mind as to what we are dealing with. Now, what about the post-CRT ECG? We can have a constellation of post-CRT ECGs depending on if it's a bi-V CRT, left bundle branch area pacing CRT, a lot CRT, or a his bundle CRT in a baseline wide QRS. The exact morphology will vary from patient to patient. Therefore, it's important to record a reference 12-lead ECG for every patient and use that as the comparison for subsequent ECGs. For bi-V pacing, it's straightforward. We are doing a posterolateral pacing. The posterior to anterior vector is best assessed in V1, which records posterior to anterior. So the lead is here, it's posterior. And once you pace posterior, you should have a V1 positive. So if you pace anterior, RV, we'll have a V1 negative QRS. Whereas and LBBB will also have a V1 negative QRS. LBBB, we are not pacing the posterior part. There is no electricity from the posterior part. The moment we start pacing from the posterior part, we find that V1 becomes completely positive. And when we combine both of them, biventricular pacing, pacing from the anterior part and the posterior part, we get a combination. That is, we get an RS in V1. You look at the V1. When we change from LV pacing to bi-V pacing, you get an R in V1, but it's not a complete R in V1. So that's the hallmark of a bi-V pacing, in the postero-anterior plane. Similarly, you have a lateral plane. The lateral plane is best assessed in lead 1, the left to right plane. It is by the presence of a Q in lead 1. The moment you start pacing and give a left to right pacing vector, you start getting a Q in lead 1. And just like we talked about bi-V pacing and V1, in bi-V pacing, you get a tiny Q and an R in lead 1. It's a combination of the RV pacing and LV pacing. The QRS becomes narrower, but you have a QR in lead 1. Now, this is not to be found in all patients, but this is a general idea. You look for a positive deflection in V1 and you look for a negative deflection in lead 1. And for individual patients, please record the ECG and keep for subsequent reference. Rarely you can have a bi-V pacing without a Q in lead 1 with a narrow QRS. Now, ECGs in left bundle branch area pacing. There are two features. One is a delayed activation of the RV free valve, meaning an RBBB morphology in V1, and a rapid activation of the LV free valve, meaning a rapid peaking of the V6 ECG. So these are the two features. RSR- pattern, an RBBB pattern in V1, and a rapid peaking in V6. There is no one definition to what should be called a rapid peak. So when you pace from the right side, you get a V1 which is completely negative. You pace from the left side, we get an RS with V1 which is RSR-. When we pace the left bundle, we will almost always capture part of the left bundle and part of the septum. So you get a Q plus an R. So you get a QR in V1. That's what you typically get. So RV septal, we get this negative pattern in V1. When you get near the LV, you start getting a little bit of left bundle pacing. So you get a tiny R prime in V1. And once we get there, we get a big R prime in V1, which is typically at least 1/3 the total QRS in V1. In this situation, if you used a very low output to pace, you might capture only the left bundle without capturing this area. So you get an R, you get at a high output, you will capture the septum and the left bundle, you get a QR. Once you drop the output, you will start capturing only this area. So the QR in V1 will change to RSR dash. So the morphology you will get will depend on whether you are pacing just above the threshold. When you record the ECG, please record it by pacing just above the threshold. That is very important. The second thing that is important is, if we pace the left bundle at a time when the native right bundle conduction comes, we are activating the right bundle and the left bundle simultaneously, you end up with a narrow QRS. So let me show this. That is an AV delay of 100 milliseconds. We are activating the left bundle a little late. There is a little bit of incomplete left bundle branch block. There is a slurring in V1, lead 1. Whereas you activate a little earlier, the slurring in lead 1 is gone, these notches in inferior leads are gone. And the QRS has become incredibly narrow. So the AV delay also defines the ECG morphology. And like we heard some time back, pacing the posterolateral vein lead plus the left bundle will be complementary. The typical feature would be you get a Q in lead 1 plus an RSR dash or an RQR in V1. So you get a combination. Like in this particular case, peripartum cardiomyopathy, not a very classical LBBB. You have a Q in lead 1 and a narrow QRS. And finally, the effect of pacing polarity of ECG in LBBB. So here is native rhythm, left bundle branch block. We are pacing in unipolar mode. You have an RSR dash configuration in V1 at all outputs. Now we are pacing the same patient in bipolar mode. We are pacing at 2.1 volt, V1 shows a Q. You pace at 2 volts, V1 shows an RSR dash. Why is this? Because see, when we normally pace, the ring electrode is floating in the blood. The ring electrode will not capture. But in left bundle pacing, the ring electrode will typically touch the RV endocardium. So at higher output, you will capture the ring electrode as well as the left bundle, meaning RV plus LV pacing, you get a Q in V1 because the ring is also captured. But at lower output, only the tip is capturing. So it is important to record in unipolar mode at a low output and then assess the QRS. Otherwise, you might get confused. And then you can make out what Shanmuga told as loss of conduction system capture. This is immediate post-implant. There is a QR in V1. 1 day post-implant, the QR is lost. But the left ventricular activation time in V6 is not increased too much. The time to R peak is not increased too much. Not bad. You can leave the lead there. But in some other cases, when there is a loss of capture, that can be judged only by low output pacing in unipolar mode. There is a big slurring in all the leads and the time to V6 peak is increased. In this case, we'll have to go in and reposition the lead. And finally, his bundle pacing in wide QRS. Now, it's important to note that conduction blocks are not degenerative diseases. They just increase resistance to cell conduction. The conduction system is there. It's not fibrosed and gone, which means when we deliver energy right into the conduction system, we can overcome any type of conduction system block. So in this particular patient who has a right bundle branch block morphology and non-sustained ventricular tachycardia, we are pacing the his bundle using a lead, and this is the native QRS, okay, RBBB-like morphology. We are pacing the his bundle from the atrial lead. The atrial lead is the his bundle. There's a pacing spike. The QRS is identical to the native QRS. You pace the his bundle at a slightly higher output. We have captured the left bundle through the his bundle, and you get the classical RSR dash morphology. You increase the output a little bit more. We have captured the right bundle and the left bundle, and you get a narrow QRS. So in his bundle pacing, the output also defines whether you capture only the his bundle or the right bundle or the left bundle. So whereas when you pace VVI from the RV, you get RV pacing. So it's important that when you do a conduction system pacing and record the ECG, take care, you're pacing in unipolar, you're pacing just above the capture threshold, and you also pace at a higher output from the capture threshold, and then evaluate all the ECGs before making a decision. So to summarize that, the type of CRT to be done depends on the analysis of the baseline ECG. Conduction system pacing and biventricular pacing can produce various pace QRS morphologies. It is imperative to recognize them to ensure adequate resynchronization. Just ventricular capture is not sufficient. So we look at all these fine points to ensure adequate resynchronization. Thank you.